I am going to be talking about anomalies of the great vessels and focusing on aortic arch abnormalities. And so we're going to first talk a little bit about diagnostic evaluation of the arches, which we heard a lot from Michelle this morning with the beautiful pictures that she showed. So it's going to be a little bit of a repeat of that. And then we're going to focus on two particular abnormalities of the aortic arch, including aortic arch obstruction as well as vascular rings. And then we're going to touch briefly on the clinical management, both prenatally as well as postnatally. So as we heard from Michelle this morning, among the various sort of tomographic views of the heart, the views that are most helpful when evaluating the aortic arch are the three-vessel view and the three-vessel trachea view. And as a bonus, what's not included here is the sagittal view of the arch, which we'll also review. So let's start with the three-vessel view. And as we heard this morning, the three-vessel view is an axial view in the upper mediastinum in the fetus that demonstrates from right to left. Here's right, here's left. The superior vena cava, the aorta, and then the pulmonary artery, as well as its bifurcation into the branch pulmonary arteries. So it's a really useful view to look at the size of these vessels relative to one another. Normally, the superior vena cava is the smallest of the three, and it kind of goes from smallest to largest from right to left. So the aorta should be bigger than the superior vena cava, and the aorta and the pulmonary artery can be around equal in size, with the PA being somewhat larger than the aorta. And as we saw this morning, if you add color to this image, you should see that the direction of blood flow should be the same across the pulmonary artery as well as across the aorta, and we'll see an example of that in a little bit. Okay, so the three-vessel trachea view is also very helpful, and we heard this morning, this view demonstrates the ductal arch, as you can see here on the left, as well as the aorta, which are both traveling leftward of the trachea. This is this echo bright thing here in the middle, and then there's the superior vena cava on the right. And as we heard, it's really important that these two arches, the ductal arch and the aortic arch, make this V shape to the left of the trachea. And this is also another great view to look at the relative sizes of this aortic arch and this ductal arch. The aorta and the MPA can be similar in size, but the aorta might be a little bit smaller, but not by much. So let's see, I think I have some arrows here. So here's going from left to right, there's your ductal arch, there's your ascending aorta, kind of leading into the transverse aorta. There's your trachea. And then in this view, you can also see the azygous vein joining up to the superior vena cava here on the right. So again, it's a nice view to see this V of the arches going towards the left of the trachea, but also allows you to see the relative sizes of these different vessels to one another. Okay, and then with color, as we saw this morning, you should really see the direction of blood flow should be the same across the aortic arch and the pulmonary artery. So color is a very useful tool, especially if you're not sure about the relative sizes of these vessels. If you put color on, if you ever see one that's going in the opposite direction, that's never normal. And then the sagittal view is a really great view to look at the aortic arch itself, and turns out to be a very useful view for coarctation of the aorta. And it just allows you to see the arches in its entirety, this is a very challenging view to get, but it is very useful, especially for coarctation of the aorta. So sometimes one of the imaging tips and tricks that we use is using your sort of orthogonal planes to image the aortic arch. So one thing that we've noticed that's very helpful is if you get your three-vessel trachea view and your axial view of the heart, this is where your ascending aorta is, and then you rotate your probe in this view counterclockwise 90 degrees, you might fall right into the aortic arch. It's easier said than done, but it is a useful way to kind of get into the plane that you need to be in to get the sagittal view of the aortic arch. So let's talk about fetal detection of coarctation of the aorta. This is, I think, one of the most challenging diagnoses for us as fetal cardiologists, because it's technically challenging because the ductal arch and the aortic arch are sort of on top of one another, so it sometimes can be very difficult to visualize the aortic arch in its entirety. And so we often depend on a lot of indirect signs to clue us in that the fetus may have coarctation of the aorta. So what has been our experience overall? Well, if you look at the literature, the earlier experience with fetal detection of coarctation was one of mostly false negatives, which this is really, we don't want this. This resulted in a lot of misdiagnoses, which can be pretty devastating and lead to devastating consequences if not identified early postnatally. But now in the current era, what we're dealing mostly with is a problem of mostly false positives, which, could be a good problem. And in one respect, where we have less false negatives, so less babies getting into trouble after birth. But a false positive is also not without consequences, especially if we alter the delivery location for that baby. We'd end up inserting umbilical lines or starting prostaglandins because we thought maybe there was a coarct and then there actually really wasn't. So there can be some unintended consequences for false positives, although they don't appear to be as dire as a false negative. So what are the indirect features that we use to clue us in about coarctation? So we'll start with the axial scan, which can give us a lot of clues to this diagnosis. The biggest one, which we heard from Michelle this morning, is ventricular size discrepancy. Very often you should expect to see RV greater than LV size discrepancy, and it can be pretty subtle, as you can see in this example here. The left ventricle is definitely apex forming, it's sort of normally sized, but there is this slight discrepancy between the two ventricles. They should really be equal in size. And then as you travel up the mediastinum, you might see a discrepancy in the size of the great artery. So if we pause this image, you can see here going from right to left, here's your superior vena cava, here's your aorta, and they're basically equal in size. That's not normal. The aorta should definitely be larger than your superior vena cava. And then finally, arch discrepancy, similarly when you get to your 3-vessel and trachea view. So here's sort of another example of that. Where you see that the aorta in this 3-vessel view is almost the same size, maybe even a little bit smaller than the superior vena cava, and that's just never normal. So here's another side-by-side of a normal compared to an abnormal. And if you pause this image here, let's just move it to where you see the arch. You can kind of get the sense, if you compare it to this moving image here, where you see this aorta looks pretty much equal in size to this pulmonary artery, both making that V shape to the left of the trachea. If you compare that to this image here, if I let it play, the aorta looks much smaller in that similar view. It's definitely much smaller than the pulmonary artery, and clearly this suggests that there's some concern about distal obstruction in the aortic arch. So using these images on the axial scan can really clue you in that there might be a distal obstruction in the aortic arch. And then the sagittal scan is very helpful because it really allows you to kind of, in many instances, make the definitive diagnosis of coarctation of the aorta, because you can actually see the discrete coarctation. So this is a nice image of a fetus with coarctation of the aorta. You can see that the left subclavian artery is pretty far away from this left carotid artery here, which is another sign of a potential coarctation. And you can see that there is this hypoplastic small transverse arch and then a discrete narrowing here at the isthmus. And then you can see where this ductal arch inserts into the aorta as well. So if you can get this image, this is really helpful because you can clearly diagnose coarctation of the aorta. Putting color on this image can also be helpful, as we've talked about yesterday and today. You want to look at direction of flow at the atrial septum, which I'll talk about in a moment. But here you might also see this continuous flow by color Doppler at the isthmus. If you kind of look in this region here, you see this continuous flow in the isthmus. It's all antegrade, but it definitely appears to hang up in that part of the aortic arch. That's not always helpful. Especially if by 2D the aortic arch looks completely normal, but you see some of this continuous flow, that might not be particularly helpful. But it can contribute some sort of evidence that there might be a coarctation, especially if it looks small in your 2D image. The problem with the sagittal arch, as I alluded to earlier, though, is if you look in this image here, you might get fooled by this image and say, I think the arch looks okay. You see the head and neck vessels, but what you're actually seeing here is you're kind of going in and out of the ductal arch and the aortic arch. You're not really differentiating between the two, and you can be fooled to think that the aortic arch looks completely normal. But if you really try to pull out the aortic arch and try to differentiate between the two, you would see that this aortic arch clearly is hypoplastic and that there's a discrete coarctation at the isthmus. Okay, so how do we, once we are concerned about a coarctation, what is the typical management prenatally? Well, obviously, as we've heard about in different conditions, we need to think about genetic associations. One common genetic association is Turner syndrome. Female patients with a coarctation should be screened for Turner syndrome. This is showing that in a large study, about 5.3% of patients with a coarctation diagnosed prenatally had Turner syndrome. It's probably a little bit of an underestimate, but it just warrants, if you have a female fetus with a diagnosis of coarctation, this should be discussed with the family, and testing should be offered to the family. The other thing we talk a lot about with families is what are the implications of diagnosing a coarctation for future pregnancies and recurrence risk. And it turns out that left-sided lesions have a very high degree of recurrence risk in subsequent pregnancies. And that there is a high prevalence of left-sided lesions in families. 40% of families have more than one affected relative with a left-sided lesion. And the recurrence risk based on multiple studies in siblings can be as high as 10 to 20% and highly concordant for a left-sided lesion. So we often, when we diagnose coarctation, we counsel that if there is a subsequent pregnancy, we recommend early fetal echo or at least a fetal echo at the usual sort of second trimester time point to assess for recurrence risk, especially if we want to make sure there isn't more severe forms of left-sided heart defects like HLHS. Okay, so the big issue with coarctation is this whole thing of predicting the need for neonatal arch repair and the need for prostaglandins. Because obviously if we know there is a discrete coarctation, the right management is to start prostaglandins, and we counsel families that the baby's going to need surgery before going home. But as I mentioned, we're sort of in this stage right now where we are overdiagnosing coarctation of the aorta prenatally, so we do have a fair number of false positives that are coming through all of our centers. This is a study that Shane mentioned yesterday, a study from CHOP that went through different features that help distinguish true positives from false positives. And as she mentioned yesterday, there are various measurements you can look at: the ratio of the valves, the aortic to pulmonary valves, the measurement of the transverse arch itself, if it's less than or equal to 3 millimeters, that was more suggestive of truly a positive coarctation, an abnormal atrial shunt, which was the most specific, if there was bidirectional shunting at the atrial septum or left to right. And serial exams, if you see these patients over the course of pregnancy, showed worsening discrepancy in the true positives, meaning these values became more obvious as the pregnancy continued. And so based on this paper, they came up with an algorithm of things that you should definitely measure if you're worried about coarctation, like size of the semilunar valves, size of the AV valves, aortic arch measurements, to try to make your best assessment of whether or not there is a coarctation or not. And more importantly, do you recommend delivery at a tertiary center, or do you recommend delivery at a community hospital without prostaglandins being initiated? So more recently, there was another paper published. It was a really large systematic review and meta-analysis that pulled together all of the studies on diagnosis of coarctation of the aorta on prenatal ultrasound. So of all the papers they looked at, this comprised over 900 fetuses, of which about 30% ended up having a true positive coarctation of the aorta. And what they found was that the highest specificity for coarctation was getting that sagittal image of the aortic arch and seeing that posterior shelf and directly seeing that narrowing at the isthmus. And the best single predictor of having a coarctation was this arch hypoplasia. So the entire arch, the transverse arch, looked small, measured probably less than 3 millimeters, as was seen in the prior study. But what they identified was that using multiple criteria perform the best in terms of finding a model that helps you distinguish whether or not that fetus has a coarctation. So I think we were still left with a lot of this issue of, we obviously don't want to miss this. So I think we're still left with this issue of false positives. And one of the things the group at Stanford has done is this concept of clinical pathway models, which I think is a really good approach to this disease, where they used a lot of these different papers that have assessed, size of the AV valve, size of the semilunar valve, size of the transverse aorta, to make an assessment of whether they think that fetus is at mild risk for a coarctation, moderate risk for a coarctation, or high risk for a coarctation. And they a priori used sort of different criteria to put fetuses in these different categories for coarctation. And then they decided on clinical pathway models based on whether there was a mildly increased risk, a moderately increased risk, or a high risk. And these clinical pathway models, they sort of a priori decided if the fetus was at mild risk, that means that they could deliver in a baby can go to the well baby nursery, doesn't need any lines placed, no PGE. If the baby was at moderate risk, doesn't necessarily need umbilical lines, but just needs sort of closer monitoring, so may end up going to the intensive care nursery. Or if the baby was at high risk, that this pretty much means they were pretty sure the baby would have a coarctation. That means that prostaglandins would be started, lines would be placed, and the baby would go to the intensive care nursery. So they kind of created these clinical pathway models, and then they went back and evaluated how well they did based on these models. And what they found was this sort of stratified risk assessment pathway led to fewer delivery location changes, less placement of umbilical lines, which means that they potentially minimize some unintended consequences of false positives. So it seems like this might be a good approach to a disease like coarctation, to have these clinical pathways based on your degree of suspicion for coarctation. And then finally, what we talked a little bit about MRI this morning, but it does seem that some advanced imaging modalities like cardiovascular MRI can be a useful adjunct to fetal echo or ultrasound. This has really been spearheaded by the group in London, where they've looked at cardiac MRI to assess extracardiac vessels, including the aortic arch. And you can see here in this image, this MRI image, this is clearly a coarctation of the aorta with a transverse aortic arch and narrowing at the isthmus, and you can see how that relates to the ductal arch here as well. So there's probably a role for cardiac MRI, not in all centers, but in some that are able to provide this clinically. If there are questions based on fetal echo, you're not sure, the cardiac MRI might be a useful adjunct to the fetal echo as well. Okay, so vascular rings is the next group of lesions to talk about. And Michelle talked about this as well this morning. I think the big thing with the vascular rings and sort of, where is the aortic arch? The three-vessel trachea view is incredibly useful to determine your arch-sidedness, as we've been discussing. Both the ductal and aortic arch, as you can see here, should be to the left of the trachea, and they make this V shape to the left of the trachea. But if you have a right-sided aortic arch, you're going to see it to the right of the trachea, and you will see as the ductal arch joins the aortic arch, instead of seeing this nice V shape, you're going to see this U shape. So here's an example similar to what Michelle showed this morning. This is a fetus with a right aortic arch. And one of the first clues to it is this is not a really, Michelle's pictures were much nicer than these, but if you look here in this 3-vessel trachea view, so this is your superior vena cava, here's your aorta, here's your pulmonary artery. There is an increased separation between your pulmonary artery and your aorta, so that's sort of the first clue. And then if you let this clip play, you can see this U shape that's being formed instead of that nice V shape to the left of the trachea. So here's left, here's right, and then here's that U shape of the ductal arch coming over and joining with the aortic arch. There. So in this case, however, this is not, when we talk about vascular rings, this is a patient with a right aortic arch that had normal branching patterns. So this does not actually comprise a vascular ring because there's nothing traveling posterior to the trachea and esophagus back here. In contrast, when you do diagnose, when you are sure that there's a right aortic arch, you should look at the head and neck vessels to see if there is a potential for a vascular ring in the form of an aberrant left subclavian artery. And for this, you do definitely need color, I think, to diagnose this because it's hard to see by 2D. So if you look at this color image here, this is right, this is left. You see this vessel traveling posterior to the trachea and the esophagus, this blue flow. This is the aberrant left subclavian artery that's traveling posteriorly over to the left side. So in this, and you have to really go, when you're doing this image, you have to go past your typical 3-vessel trachea view and continue going up to see if there's anything crossing posterior to the trachea and the esophagus. So this is a vascular ring, and the counseling for this is a little bit different than if you just saw a right aortic arch with normal branching pattern. These patients, some may require surgery at some point in life to relieve obstruction of the trachea or esophagus, and there are some implications for genetic associations like 22q11. And then finally, double aortic arch, which we saw examples of this morning as well. This is definitely a vascular ring. And if you look at this image, I kind of stopped it right there. So here's from right to left, here's superior vena cava. This is the double aortic arch here that is encircling the trachea. This is the right arch and this is the left arch. And then you can see the ductal arch way over on the left. There. And if you add color really helps in this situation because it kind of looks like what we call this donut sign, where these two, the right and the left arch, basically are encircling the trachea. And you can clearly see that here by color. So the axial view is very useful to diagnosing a double aortic arch. The sagittal view is actually not that helpful in diagnosing a double aortic arch. Here's that same patient with a sagittal view. You wouldn't be able to really diagnose a double arch this way. You really need to use that axial view and use that 3-vessel trachea view to show those two arches that are encircling the trachea. And then what I was talking about earlier, the genetic associations, there is a potential genetic association of vascular rings with 22q11.2 deletion syndrome or DeGeorge. Overall, 24% of patients that have isolated aortic arch abnormalities can have this deletion syndrome, but by far the double aortic arch is more common. So if we diagnose that, we do counsel the families about this association and recommend genetic testing. And then in terms of postnatal management for double aortic arch, this will require repair for sure. And these patients usually have more symptoms early on as compared to other forms of vascular rings. They can have symptoms in infancy and most actually do require early repair. So for these patients, we often recommend delivery in a place that can manage any airway issues that might be occurring from a double arch. So sometimes they don't actually deliver in community hospitals. They deliver in, our hospital or another hospital that is able to manage any airway issues that might arise from having a double aortic arch. So that's all I have for this talk. The take-home points for aortic arch abnormalities are to use your axial imaging to look at your 3-vessel trachea view is really useful. for both aortic coarctation to look at this, sort of size discrepancy between the vessels, as well as for vascular rings like a double aortic arch or a right aortic arch. The sagittal view is incredibly useful for coarctation of the aorta to rule out discrete obstruction. In all of these cases, most can suggest a genetic abnormality, so that should be a part of the counseling process. And in certain cases, it may alter postnatal delivery for these patients, both location as well as management. Thank you.